Hello and welcome to the American Association of Nurse Assessment Coordination webinar, Take Action to Prevent and Manage Multidrug-Resistant Organisms and C.difficile in the Nursing Home. It is now my pleasure to introduce our speaker for today, Dr. Nimalie Stone. Dr. Stone is the medical epidemiologist for long-term care at the Center for Disease Control and Prevention, CDC. She is a board-certified infectious disease physician who has a research and clinical background in managing infectious and antibiotic-resistant pathogens in the elderly long-term care population. In her role at the CDC, she develops guidelines, educational resources, and quality improvement programs to promote infection prevention and surveillance in the long-term care setting. She has participated in several state-based and national initiatives which support long-term care facilities and infection prevention activities and raised awareness of the importance of including long-term care providers in efforts to reduce healthcare-associated infections. So now, with no further ado, it's my pleasure to go ahead and hand the floor over to Dr. Stone. Dr. Stone, if you are ready, it is all yours.
Great. Thank you very much, and good afternoon. It's really a pleasure for me to have the chance to share with you some actions that you can take locally to prevent and manage multidrug-resistant organisms and C. difficile in your nursing homes. I'd like to take a moment to thank my colleagues at the American Association of Nurse Assessment Coordination for hosting this webinar and making this presentation open and available to so many people. I wanted to share some of the information about continuing education credits for those of you participating today, and also mention that I personally have no conflicts of interest to disclose. So this slide shows you the objectives I'm hoping to cover during this webinar. We're going to focus on how multidrug-resistant organisms, or MDROs, and C. difficile emerge and spread in our facilities so that we can understand the strategies to prevent them. It's a lot of information to pack into a fairly short time, so I'm going to move a little quickly through these slides. Please jot down your questions and send them through the webinar Q&A tab so that we can be sure to answer them at the end of the session. But before we jump into prevention, I want to make sure we're all on the same page about these bacteria. And since I'm an infectious disease doctor and a little bit of a nerd, I always like to start with the basics in the laboratory. So please forgive me if this is review for all of you. When we send a specimen to the lab to culture for bacteria, they identify the bacteria using a series of steps. One of the first steps is to look at them under the microscope using a process called the gram stain. What you see in this picture are two different types of bacteria. The gram-positive bacteria staining purple because their cell walls take up a violet dye in the gram stain process, and the gram-negative bacteria looking pink or reddish because their cell walls can't hold on to that violet dye and they take up a counter stain. By knowing the size, the shape, and even the growth patterns of cells in the lab, it helps us to identify them and also helps us to create new antibiotics targeted at those different characteristics to attack and kill those bacteria. Now, you are likely very familiar with the common bacteria causing infections among your residents, but here they are organized for you by their gram stain and shape. The gram-positive cocci in the top of the picture are named because of their round, circular shape. Streptococci and staphylococci are bacteria that we can culture from our skin and often from wounds. Specific examples of these bacteria are Group A Streptococcus and Staphylococcus aureus, both of which can cause wound infections and other severe infections. C. difficile happens to be a gram-positive rod, and we'll talk a little more about C. diff in a few slides. Most of the gram-negative bacteria we encounter in healthcare look like little boxes under the microscope, and we call them bacilli, or rod-shaped. Many of them are in the family Enterobacteriaceae, which is a very fancy term for bacteria living in the intestinal tract. And entero means intestines, Bacteriaceae means bacteria, so it's a pretty descriptive term. Now you know these bacteria as E. coli, Klebsiella, and Enterobacter, which you probably recognize as common causes of urinary tract infections in our population. Antibiotics, of course, are a group of drugs which we've developed to kill the harmful bacteria that cause infections. We have to remember, though, that our bodies are naturally colonized with lots of helpful bacteria, and those helpful bacteria also get disrupted and killed when we take antibiotics. Killing that normal bacterial flora on our system often leaves us vulnerable to the more resistant or more aggressive bacteria. An example of this is when C. difficile gets into our GI tracts because antibiotics have wiped out the normal bacteria in our guts. We have many different classes of antibiotics, such as the penicillins, the cephalosporins, the fluoroquinolones, and the aminoglycosides. Some of these drugs have a very narrow spectrum of killing. One example is the drug that we use to treat C. difficile, called metronidazole. It only targets bacteria which aren't able to survive in oxygen, and we call these anaerobic bacteria. Other classes of antibiotics have very broad spectrum of killing. An example are the carbapenem antibiotics, and these are very active against gram-positive bugs, gram-negative, and even some of the resistant organisms. And this big gun antibiotic class we usually think of as our last line of defense against many significant infections. However, now we are seeing resistance emerging to even that powerful group of drugs. And resistance is the term that we use when we see antibiotics lose their killing effect on bacteria. Resistant infections can often be more severe, and they are, because of their resistance, harder to treat and often more costly. So given that background, multidrug-resistant organisms are bacteria which have developed important antibiotic resistance patterns. Sometimes one key antibiotic resistance pattern will define an MDRO. Examples of this are methicillin resistance in Staph aureus or vancomycin resistance in Enterococcus. But other times, bacteria acquire resistance to many classes of antibiotics. For example, the carbapenem resistance that I just mentioned doesn't only take out that one powerful class of drugs, but it often travels together with resistance to many other antibiotic classes as well. And that can become very scary for us when we're talking about treating our patients. So this slide shows you a table which quickly summarizes some of the important MDROs that we track and try to prevent in healthcare settings. Now, in the nursing home setting, we have a lot of data showing that antibiotic resistance is a real problem impacting our residents. What you see are the rates of resistance occurring among gram-negative organisms that colonize residents as high as 20%, and even higher amounts of MRSA colonizing our residents, up to 50% having carriage in their skin or in their nares, the nose, of methicillin-resistant Staph aureus. Unfortunately, I suspect these numbers of colonized residents with MDROs will only continue to rise because we are admitting more residents directly from hospital settings, and this post-acute care population carries many of the risk factors we know allow people to become colonized and infected with MDROs. Now we're going to shift gears for a moment and talk a little bit in more detail about Clostridium difficile. I mentioned earlier that C. diff looks like a gram-positive rod in the lab, and you can see that in the slide at the top, in the picture at the top of the slide. It's also an anaerobic bacteria, meaning that it doesn't like to grow in environments where oxygen is present. It kind of helps explain why C. diff and other anaerobic bacteria often live in our intestinal tracts. But then you may wonder how C. diff can survive and spread in the healthcare setting once it gets out of our bodies. Well, C. diff has a special ability to convert itself into a spore. The spore form of the bacteria is protected by a hard outer coating that allows the bug to exist even when it's in an unfavorable place. The bacteria lie sleeping in the spore, and once it gets back into a good environment where it can grow, like someone's colon, then it can wake up and begin multiplying again. And when it starts to divide and grow, it produces the toxins that cause irritation to the lining of the colon that we call colitis. C. diff infections are mainly acute diarrheal infections, and unfortunately they can be very severe in the older adult population, leading to a lot of hospitalizations and a higher risk of relapsing disease. Infected patients shed high numbers of the spore form of C. diff in their diarrhea. And we know from experience that this can get all over people's skin and into their environment. Even people who have resolved their diarrhea can continue to shed low levels of C. diff spores into their environment, especially in the first few days to weeks after their infection. Once the spores get into the environment, it's easy for them to contaminate the hands of caregivers or the equipment that we used to take care of other people. C. diff, like other MDROs, is also a significant and growing challenge for nursing homes. More than half of healthcare-associated C. diff infections are occurring in long-term care settings, and a large number of people entering nursing homes are colonized with C. diff even when they aren't actively sick. Another large number of people will acquire C. diff when receiving care in the nursing home setting. We know that antibiotic use is a major risk factor for C. diff colonization and infection. And interestingly, fluoroquinolone antibiotics like levofloxacin, which are often one of the primary drugs that we use to treat patients in the nursing homes, have been associated with more severe C. diff infections. So what is it about healthcare that drives the presence of these bad bugs? Well, we do things in healthcare that contribute both to the development and the spread of these organisms. And you can see some of the examples of developing MDROs and C. diff include antibiotic use and use of medical devices or presence of wounds. And spread happens when we have high levels of colonization in our facilities, and we have the transmission of these organisms either via the hands of our caregivers or the contamination of the environment. So these next few slides will quickly review some of these concepts. Despite our best intentions, using antibiotics will almost always lead to the development of resistance. It's not that the drugs themselves cause resistance, but they create a situation where the strains of bacteria which naturally have resistance are allowed to survive because all of the susceptible strains get killed off. At a community level, the amount of resistance depends on our levels of antibiotic use. And what you see in this graph shows you that as the number of levofloxacin prescriptions increase over time, as illustrated by the dotted line, the resistance to levofloxacin in E. coli in that community also starts to rise, which you see on the solid line. And there's a bit of a time lag before the resistance emerges and becomes identified, but then it pretty much steadily rises along the same trajectory as those rising numbers of prescriptions. you may have seen resistance develop to the commonly used antibiotics in your facility over time. Now, it may seem surprising that the use of medical devices somehow is related to the development of antibiotic resistance. But what we've learned is that whenever we place a device into the body, a sticky film of bacteria, which we call a biofilm, will form on that device. The picture in this slide could represent an indwelling urethral catheter placed in the bladder. The bacteria sort of flowing and floating around in the urine of the bladder notice that plastic catheter surface and float down and land on it, secreting proteins and sugars along that device that allow them to stick to it. Then they decide to call their friends over who join them and land, and pretty soon you have a bacteria-filled slime layer that coats the entire surface of the catheter. It's not the most pleasant image. I'm hoping none of you are listening over lunch. But if you've ever cared for a resident with a catheter-associated urinary tract infection, you've probably seen this in action. You know that it's very hard to get rid of all of the bacteria in their urine, even when you use powerful antibiotics. And frequently, after the antibiotics are stopped, you not only see the bacteria return, but now that bacteria is resistant to the drugs you just used. This happens because our antibiotics don't effectively penetrate the sticky biofilm, allowing bacteria within it to be sheltered from the killing effect of the drug. When organisms see less than effective levels of drug, it's more likely that they'll develop resistance or acquire resistance and then share that with the other bacteria with them in the biofilm. So we see how antibiotics and devices can lead to the development of resistant organisms. Now let's look at ways where it can spread. The idea of colonization pressure is relatively straightforward. The more people around you that have a bad bug, the more at risk you are to get it from them. This has been shown in studies of many different MDROs as well as C. difficile. And one of the important messages we have to remember is that both the asymptomatic carriers, people who have these bugs but aren't feeling ill from them, as well as the actively infected people, will contribute to that source reservoir for transmitting those bugs to others. I like these pictures because they really explain this concept very well. So here's a question. Would you rather be the person in Unit A where only one other person around you has an active C. diff infection, or the person circled on Unit B where you're pretty much surrounded by sick people? It's pretty clear which person has a greater risk to acquire C. difficile from the people surrounding them. And that's pretty much an example of how that colonization reservoir can affect how easily we transmit and spread these bacteria around. Now, this image is a reminder of me to shift into talking about the most common way that organisms are spread. And that, unfortunately, is on our hands. And there are a lot of posters and flyers and educational materials that are available from the CDC as well as the WHO, the World Health Organization, to help raise our awareness and improve our techniques around hand hygiene so that we don't spread organism on our hands. This study looked at the type of bacterial contamination that occurred on the hands of healthcare workers when they cared for residents in a long-term care facility and got tested just before they performed hand hygiene. And when I asked people to guess what type of bacteria was most frequently identified and cultured from the hands of these staff members, often people guessed Staph aureus, because that's the skin bug. That's the one we always think of. But what was really interesting is that the vast majority of volunteers had gram-negative bacteria colonizing or cultured from their hands immediately following their direct care and interaction with their residents. In fact, over 60% of the volunteers who had their hands tested grew gram-negative bacteria. And remember, most gram-negative bacteria, those Enterobacteriaceae, they live in the GI tract. They colonize the stool and the urine. So that gives you an image of what we are carrying on our hands when we leave our residents' rooms before we clean them. Speaking of residents' rooms, this is a really famous image of all of the places in a hospital room where a multidrug-resistant organism, in this case it was vancomycin-resistant enterococcus, could be cultured. Even though this room, at first glance, looks pretty clean, and it's clearly not occupied, the bed is made, it looks like everything's set up for the next person to come in, and yet almost everywhere in every surface they were able to isolate vancomycin-resistant enterococcus, and it's enterococcus, so take a guess at where that bug lives in our system. And it's a reminder that even when things look clean, they may not be disinfected, and it's this reservoir in the environment that allows for, again, spread of organism from person to person. We have to be mindful of just how long these organisms can actually survive in the environment as well. And I've mentioned already about C. difficile and how, because of the spores, it can actually hang out in the environment quite happily for months at a time. And it can be harder to eradicate even with typical cleaning products. But even methicillin-resistant Staph aureus, vancomycin-resistant enterococcus can hang out in the environment for weeks, and some of the gram-negatives can be there for over a month. So again, we have to really think about our cleaning strategies in addition to our hands when we talk about spread and contamination of these organisms. And that's a good segue into talking about the prevention strategies that we'd like to touch base on how we can do things at the bedside or in our facilities to help us to reduce the likelihood of transmitting these bugs. Now that we know how they move around, we can target activities that could prevent it. The top activities that I've put in white text are the ones we'll focus on this afternoon, and that includes consistent performance of hand hygiene, using gowns and gloves appropriately, recognizing residents with risk factors for colonization and handling them appropriately, and cleaning and disinfecting shared equipment, rooms, and surfaces. We'll also briefly touch on the role of antibiotic use and device use, but honestly, antibiotic use could be another hour-long webinar for another day. So, hand hygiene is something that we should all be very familiar with, and these on this slide you see the list of different opportunities where we should be performing hand hygiene. The ones that are in white text are those opportunities where any form of hand hygiene, whether it's alcohol-based hand rubs or using soap and water, would be appropriate. Those bullets that are highlighted in orange toward the bottom of the slide are really situations where soap and water is the preferred method of hand hygiene over the alcohol-based hand rubs. And that's because we know that when we have visibly soiled or dirty hands, it's hard for the alcohol to disinfect until we remove the dirt and grime. When we have residents with suspected diarrhea, we're thinking about organisms like C. difficile or norovirus, which may not be as effectively killed by the alcohol-based hand products, and that's another reason why we encourage soap and water hand washing after the care of those individuals. But even though we all seem to know what the right times might be for doing hand hygiene, we may not all buy into it. And this is an interesting survey that was done from over 1,000 nursing home staff members representing almost 20 facilities across several states. And what they did was ask them questions about their knowledge as well as their belief about the hand hygiene guidance. And in particular, this is focused on the 2002 CDC hand hygiene guidelines. And interestingly, 30% of the people responding to this survey said, I'm not going to change my personal hand hygiene practices based on what's said in some guideline. And follow-up question revealed that 1 in 5 people thought the guidelines were a little impractical for the nursing home setting. Interestingly, the vast majority of people who took a knowledge questionnaire based on the hand hygiene guidelines didn't score in the highest levels. Only 30% scored over 85% correct on this survey. So they may believe they know what is in the guidelines, and they may believe that those guidelines don't apply to them or aren't practical for them, and yet they may not be as familiar as they think. So it was just interesting to understand that there may be a disconnect between what we are trying to teach people and what they think is important. And we have to be aware of that and understand that disconnect. Another thing we have to be aware of are the barriers to compliance and adherence to hand hygiene. And the other piece of this survey asked people, why is it that people don't perform hand hygiene even if they know they should be? And almost 20% said it was lack of access to appropriate hand hygiene supplies. That went up to close to 30% when specifically asked about the availability of alcohol-based hand rubs. A lot of folks said, I'm not doing hand hygiene because I wore gloves, so I don't need to perform hand hygiene. And that is a very common misunderstanding. Gloves by themselves are not adequate for protecting hands from getting contaminated. And so we really have to do both hand hygiene and wear gloves in certain situations. A very large group said it was workload, just forgot. And that's a very honest answer, and I'm sure very real. If we don't make hand hygiene accessible to our caregivers, it's very hard for them to incorporate it into their workflow. And the other thing that was really striking to me was that over 50% said they very rarely received any feedback on their hand hygiene practices. And this gets at our feedback supplementing our education, and that's a really important message. So hand hygiene is known to be the primary, most effective way to prevent and prevent the transmission of infections, and yet we still have a lot of confusion about how to perform it, when to perform it, and even when certain hand hygiene products are preferred over others. And this is particularly highlighted around issues with C. difficile. There's a lot of information available that shows alcohol-based hand rubs aren't effective against killing C. difficile spores. But what's interesting is they're very effective and often more effective than hand washing with soap and water against all of the other MDROs. So we have to be careful about our messaging. We want to encourage and recommend soap and water hand hygiene after caring for C. difficile patients, certainly when there's outbreaks of C. difficile in our units, and even after caring for people with forms of diarrhea that we haven't identified yet, just in case it could be C. difficile. But we don't want that message to inadvertently discourage the use of alcohol-based hand products in general, and even in the walking in the room before contact opportunities where alcohol-based products may be very effective at reducing the burden of all the other potential pathogens that we can share in healthcare settings. It's also important that people understand that glove use is a critically important piece to protecting their hands from contamination, because really even spores can be hard to kill and remove with soap and water hand hygiene as well. In the big picture for our facilities, we want to make sure that there's adequate access to both options when it comes to promoting good hand hygiene. I'm going to move now to contact precautions because the issue of glove use when it comes to C. difficile prevention is a great segue. In general, gown and glove use should be a part of the direct resident care for residents who are identified with active infections from organisms like C. diff or other multidrug-resistant organisms. And we want to make sure that our caregivers are putting on those protective pieces of equipment prior to going into the room and taking them off prior to walking out, because we know the environments of the rooms, as I showed you in that slide of VRE cultured all over the room, can be in the environment along with in the direct handling of a resident or patient. So we encourage people to be protected as they go in and out. Also, if possible, it's good to dedicate items specifically for the care of residents who are in contact precautions, and that might be giving dedicated blood pressure cuffs, having single-person use stethoscopes and things like that. We also try to cohort individuals with MDROs or C. diff, if possible, or place them in private rooms during their active infections to try to reduce the likelihood that those bugs can get spread to other people who are close by and in proximity to them. And again, one of the important things to do is to make sure we're observing whether our caregivers are using gowns and gloves appropriately and providing them with appropriate feedback. So another study looked at the perceptions of nursing home staff when it came to using contact isolation for organisms like MRSA and VRE. Here they interviewed a smaller number of staff members, about 400 were approached, and of that about 350 responded, representing 7 community nursing homes. Some of the feedback they provided was that less than half would actually change their daily practices if they became aware of the presence of an MDRO. And that struck me as a little surprising, if not for protecting the residents themselves, maybe because people are a little more concerned about picking up an MDRO and taking it home to their own family. A large proportion of people in this survey expressed concern that isolation could negatively impact a resident's psychosocial well-being, and they specifically cited things like depression as being something they worried about when it came to using isolation. A much smaller proportion of nursing home staff expressed concern that isolation could lead to neglect of residents, which is interesting. We do know that in hospital environments there have been studies showing that patients who are in contact isolation may not get as frequent visits from healthcare personnel compared to those that are not. We know there are other challenges as well with implementing contact precautions in this setting. A lack of private rooms and the limited ability to move residents can really make it hard for us to do things like cohort people even when they acquire new infections. We know moving people from room to room is very disrupting to both staff and their residents. And the other thing to be aware of is that we may know of some of the people coming into our facilities that are carrying a multidrug-resistant organism or C. diff, but we may not know all of them. And we don't often do active surveillance testing to identify that group. Understanding how long people should be in precautions is also a challenge, and we can't really restrict people's movements and participation in social events and therapy for long periods of time. And as I mentioned, there is likely a large population of people coming into our facilities that are unrecognized but carrying these bugs, and that can really underestimate our source population for transmission. So what are some of the things that we can do? Well, one thing to do is consider strategically putting residents into places in the facility based on risk factors for MDROs, even if you don't know for certain they have one. Examples of risk factors include recent or current antibiotic use, the presence of medical devices or wounds, bowel and bladder incontinence, or a lack of mobility. Anything that increases a person's dependence on caregiving will increase the likelihood that people will bring things to them on their hands. If you know an individual's risk factors, you can try to put them strategically with roommates that may not share the same level of risk. And that can reduce the possibility that a multidrug-resistant organism can move from one person to another. On the other hand, if you have two vulnerable people together, for example, both of them having an indwelling urinary catheter, I might inadvertently transmit a multidrug-resistant gram-negative rod from one person's urinary collection system to the other if I don't perform good hand hygiene and gown and glove practices. So by dividing those people up away from one another, I could reduce accidental transmission. The other message, though, is that if you have a stable set of roommates who have been together for a long time, you may not have to disrupt them just because a new culture result becomes available. Roommates who have been together for a long time have often already had the opportunity to share an organism in the past, even if we've only become aware of that organism recently. Another approach to consider is what I call a tiered strategy to using gown and glove use. For example, if I have a resident that has a lot of those high-risk exposures for either being a carrier for an MDRO or being at higher risk to acquire an MDRO, I might use gowns and gloves during the intimate care I provide for them, like bathing, toileting, and AM and PM care. And again, those are the same risk factors we've already touched on that put somebody at a higher likelihood of either developing resistance or already being a reservoir. Now, there are some situations where I may consider restricting an individual's movements in addition to using gowns and gloves during their care, and those are pretty narrow time periods where someone has active symptoms of a contagious infection, whether it's nausea and vomiting and acute diarrhea that might be concerning for norovirus or C. diff, or even new coughing, sneezing, and fever that might be concerning for influenza. And in those situations, it's important to try to contain that quickly so that you don't see those infections spread among others in the home. But often you can restrict the time that you're using those. You can limit the time that people are in that more higher level intensive restriction until you identify and start treating the infection or their symptoms resolve. Another common question I get is, when do we stop contact precautions? And the real honest answer is we don't have a single best strategy for when to discontinue contact precautions for MDRO carriers in any healthcare setting. In the hospitals, people are often remain in precautions for the whole time they're in the hospital, but that's a relatively short period of time, and people are often not well enough to wander around the facility anyhow. But in long-term care and nursing homes, we know that that's not going to be good for somebody's recovery and rehabilitation. So the general rule is to resume basic standard precautions once the high-risk exposures and their active symptoms have discontinued, and resolved. Now, for C. difficile, there have been studies showing that individuals can continue to shed spores for several days after their diarrhea has resolved, and that might mean if we extended our gown and glove use for the care of those individuals, we could further reduce transmission of C. diff spores. But I think that's a practice that's taken hold in some places, but it's not universally accepted yet. The most important thing about contact precautions is that our communication to our healthcare personnel, caregivers, residents, and families about our policies, and clearly documenting why we start and why we discontinue these precautions is a critically important piece, so that everybody understands why we're doing what we do and we can kind of audit our decision making. So I'm going to move now to cleaning and disinfection and touch on the issues related to contaminated surfaces and equipment. We know that these contaminated environments can certainly contribute to the spread of MDROs and C. diff, and you can see the various places where we've cultured these organisms. The room contamination can be very high for infected and colonized people, depending on the pathogen which they carry. Up to 30% of people with MRSA can shed it into their environment. Much higher, close to 75% of people infected with C. diff can shed it into their environment. And we know that individuals have acquired MDROs just from being admitted into rooms that were previously occupied by known carriers. This graph just shows you a snapshot of some of the most frequent places where C. difficile can be cultured across the environment, and the highest risk places, not surprisingly, are in the commodes and toilets and bathrooms. But there's also C. diff occurring on the curtain rails, the bed frames, and even the door handles. And so again, we have to be thinking about these high-touch surfaces in our cleaning practice. When we look at cleaning strategies, it's really important to look at the adequacy and the effectiveness of our cleaning. And there's been a lot of recent studies looking at how can we help improve our cleaning practices through auditing. Using things like fluorescent markers, there's products that basically come in a powder form, and when you set them down on the environment, they look invisible to the naked eye, but they light up when you shine a black light over them. And those fluorescent markers have been used to assess the quality of cleaning. And before people were educated and shown how well they were doing with cleaning, only 47% of the high-touch surfaces that are often contaminated were being adequately cleaned. They were able to improve how well those surfaces were being cleaned when they started auditing and showing environmental services staff how well they were cleaning using those fluorescent markers. To some degree, it's important to really make sure people are cleaning well before you then audit and look at the types of products you're using. However, when it comes to C. difficile spores, you do want to be using cleaning products that have labeling claims that they are sporicidal in order to make sure that the C. diff is being effectively removed. Another piece of the environment is the use and cleaning of equipment. And some of the strategies that we can employ to improve this are to make sure that we are clear about who is responsible for cleaning various pieces of equipment, whether it's environmental services and housekeeping or it's the nursing staff that will be assigned to clean certain pieces of equipment. And that may vary depending on who's using them or where they're stored. Certain pieces of equipment like glucose meters have to be designed for use among multiple people. Otherwise, frequent cleaning may actually affect the functioning of the device. So you have to know your equipment and make sure that you have a process that can safely clean and disinfect them if that piece of equipment is being shared among different people. And maintaining logbooks is a really great way to make sure that your big pieces of shared equipment are getting cleaned and disinfected on a regular basis. I know we're coming toward the end of our time, so just a couple of thoughts about device utilization, being aware of why we're using devices. You all do a very good job of this in the nursing home setting, especially around urinary catheter use, and you are far ahead of hospitals when it comes to reducing device use in your populations. But making sure also that when staff members are handling and maintaining these devices, they're very comfortable and trained on the infection prevention practices related to insertion and handling to reduce, again, the likelihood that those become portals for transmitting resistant organisms. And as I mentioned, antibiotic stewardship is a really critical piece in the control of MDROs and C. difficile. Understanding why and documenting indications for antibiotic use is a very important first step in looking at how well we're utilizing these drugs. Having protocols to help with our assessment of infections and communication between frontline staff and providers is another important piece to improving how antibiotics are used. Now, the last few slides in this presentation are highlights from national initiatives and resources that I wanted you to be aware of when it comes to infection prevention in general and some of these bacteria like C. difficile in specific. So the Department of Health and Human Services has released a national action plan to address prevention of infections in long-term care settings. And they really focused on nursing homes and skilled nursing facilities when they set up their priority goals in this action plan chapter. And you could see the link to that chapter on this slide. Those priority goals include reporting and preventing C. difficile infections. And so I want to touch on what they mean by reporting. There is a national infection reporting system called the National Healthcare Safety Network that the CDC manages. It's a web-based system that allows a healthcare facility to report infections to the CDC using a web-based interface. And what's nice about the system is it uses standardized infection definitions to identify events. So no matter what hospital or what nursing home you're working in, people using the system are counting and defining infections the same way. Now, locally, facilities can use this data for their own surveillance and internal quality improvement activities, but we use the data at CDC to establish national benchmarks and to track our overall improvement in efforts to prevent healthcare-associated infections across this country. I'm excited to share with you that NHSN has a reporting option designed specifically for long-term care facilities. Now, this is relatively new. It launched in September of 2012, but since its release, we've had over 150 facilities voluntarily sign up and start using the system. And that's a very exciting thing for us because for a long time, we haven't been able to tell people the burden and the numbers of infections that are happening in long-term care settings. And getting people enrolled and using the system is a big step to getting there and having that information to share. MDROs and C. difficile can be tracked in the NHSN system based on laboratory-identified events, basically using a lab culture as a proxy for your infection surveillance. And a couple of benefits to this is that the definitions that are applied in the lab ID event criteria for long-term care settings are the same as the definitions applied everywhere else across healthcare, which means we're all counting in the same way. It's also a little bit easier to do surveillance using laboratory data because you don't have to go to the residents' charts and extract a lot of clinical information to track these. This is a screenshot of a very new, just launched last week, infection prevention website for long-term care settings that the CDC released. And it has a lot of resources organized by different pathogens and targeting different providers, whether you're residents looking to understand more information about infection prevention or your frontline staff members working and looking for resources. So I encourage you to take a look at that. And also, I'm sure many of you are familiar with the Advancing Excellence in America's Nursing Homes campaign. And the Advancing Excellence campaign released an infections goal last year in 2013 in the summertime. The infection prevention goal became fully active, and I'm just going to show you a few pieces of information about that goal. The goal was focused on C. difficile prevention, and there were several prevention strategies that were identified for process improvement. But what you've heard today is that using any of these strategies will likely reduce the spread of all the other MDROs in your facility in addition to C. diff. And you can find a lot of resources on the AE website, including fact sheets for your nursing home staff, leadership, and your residents and families, as well as checklists so you can assess how you're doing with some of these prevention strategies currently and get some ideas about activities you could implement using those checklists as well. There's also links to lots of websites with tools and resources to support your activities. And this is just one example of the infection prevention assessment checklist, and this is the hand hygiene checklist for you to take a look at. So to conclude, MDROs and C. difficile are really a growing problem in long-term care settings, largely driven because the population entering our facilities now have many risk factors for infection and colonization with these organisms, and that's not something that's going to change. So if we understand how these organisms emerge and spread around our facilities, it can really help us focus our prevention efforts at the bedside. And I would encourage you to focus on one or two strategies for your facility this year, and then use those existing resources to get materials to help you out. And I'd like to leave you with one last idea, which is that education is only the first step. We have to provide that ongoing feedback and monitoring to our staff members to really maintain their awareness of the problem and also continue to get their buy-in and support. So I hope that this has been a good introduction for you. I'm happy to answer some questions with the time we have remaining. And if there isn't enough time, we will try to follow up and answer your questions after this webinar. So please don't hesitate to send them in.
Okay, great. Thank you. So we're going to go ahead and start taking some questions, as Nimalie just mentioned, or excuse me, Dr. Stone just mentioned. If you do have a question and you're not sure how to ask it, just head over to the Q&A tab, and you'll just want to select Ask New Question and then hit Submit. So let's go ahead and get right to the questions. The first one we have only shared bathrooms at our facility. For a patient with C. diff who is on contact precautions, we have the patient use a bedside commode and wash her hands with soap and water at the bedside. We don't have patient use for the shared bathroom at all. Would it be reasonable for us to allow the patient to wash their hands in the bathroom, or should we continue to avoid that?
Thanks. That's a very good question. It's a tough one because, of course, we know that if there's shared bathrooms, some people going into those bathrooms may not have C. diff, and their exposure to that organism can result in their acquiring it. Your current strategy sounds like you're doing a great job of separating those people who are actively infected with C. diff and keeping them from having limited contact with those common facilities. And if it is feasible to do so, I would encourage you to at least continue that while they're actively having symptomatic diarrhea. I know that can be hard to sustain for a long period of time, especially if you don't have sinks that are outside of the common bathrooms. The other strategy you could use would be that whoever is helping that resident with their toileting and doing their hand hygiene in the shared bathroom would then be responsible for wiping down and cleaning the surfaces of the bathroom after that resident has finished in it. And that way you could use that shared sink, but you would still ensure that other people going in there would be relatively protected.
Okay, great. Thank you. Another question here. Sorry, just looking through these. We put our patients with E. colitis on contact precautions. Should we do that for all bacteria, UTIs involving bacteria from the GI tract?
So I would say it's probably most important to use the contact precautions, and by that I mean gown and gloves for direct care, when you know you're managing somebody who has an antibiotic-resistant organism or something like C. difficile colitis. It can be burdensome and expensive to use gowns and gloves and have residents in precautions for long periods of time, or to have large numbers of people in precautions at the same time. And so I think it's a balancing act between the risks and the benefits, and I think for that reason, having a blanket policy for any infection to be managed in contact precautions might be a little bit burdensome for a facility. It could also cause some fatigue among your caregiving staff because they may not, if they get a little weary of using gowns and gloves all the time, they may not use them when they're the most important. And so those might be a few things that would lead me not to have a blanket policy for all infections to be in contact precautions, just those that are from these resistant organisms or C. diff, which are particularly high risk.
Great, thank you. Another question here. What is the recommendation about doing additional C. diff cultures to see if a patient has cleared the infection? Is it better not to do a clearing culture and just monitor symptoms?
Thank you very much, whoever asked that question. It's a fantastic question. The test that we do to identify C. difficile infection is not designed to demonstrate response to treatment, or what we call a test of cure, meaning it is not designed to confirm that somebody has cleared their C. difficile after being treated. Oftentimes when people test after a resident has received treatment for C. diff and resolved their diarrheal symptoms, they may still detect the toxin in their stool samples, and this positive test can lead to unnecessary additional antibiotic treatment for the C. diff and the extension of people staying in precautions beyond the point where they may need to. Certainly, once somebody's diarrhea has resolved fully, there would be no reason to add another course of therapy just because they tested positive in their stool. So the right strategy is what you mentioned, which is to follow and monitor somebody's symptoms. And when their symptoms resolve, use that as the time frame to consider discontinuing precautions. I do not recommend, and there is no guidance that recommends sending post-treatment C. difficile tests.
Great, thank you. Another, is it better to use antibacterial soap versus regular soap?
This is an issue that's gotten some additional exposure in the media recently because they're recognizing studies are not really demonstrating that antimicrobial soap is any better or more effective at disinfecting hands than regular soap. And in fact, there may be concerns that using these additional antiseptics or antimicrobials in soap could actually change the environment, where bacteria in the environment may become less susceptible to being killed by these agents. So there is no recommendation that antimicrobial soap is preferred or better than regular soap when it comes to hand disinfection.
Great, thank you. Let's see here, another question. If MDRO is a wound that is covered, should gowns, gloves be used for general care, i.e. toileting?
So I think the question is, if you have a wound that is colonized with an MDRO and you can cover that wound and it's contained, there's no drainage, then is it still necessary to use gowns and gloves during direct care? I think that's a fair question, and you could approach it from two different ways. generally speaking, if wounds are can be contained, covered, dressings are clean and intact, standard precautions, good hand hygiene during care would be adequate. However, large wounds, wounds that are actively draining, or wounds in places where the dressings can become compromised quickly and there can be breaches in the wound dressing, those might be all situations where I would encourage gown and glove use during care. And this would be for wounds that are known to be colonized or even not known to be colonized, because recall, we don't always know what somebody's carrying when they come into our facilities. And we know that the presence of large open wounds are a very high risk factor for acquiring multidrug-resistant organisms as well.
Okay, great. I think we're just going to do a couple more questions. We have a lot in here, so we do apologize if we don't get to your questions today. We do pull a log of all the questions, so we will have them stored. And again, we apologize if we don't get to them all today. Another question here, we are a rehab facility with small double rooms. Do you recommend that we do not have a patient on C. diff precautions leave their room for therapy? We have a therapist, gown and glove, and we return the patient to his room if toileting is needed.
So it's sounding like it would be hard to provide therapy in the room for residents who are having C. diff, and that may be why you try to move them into the therapy area or the rehab gym to get their therapy. And generally, I think that makes a lot of sense. Those residents who are having active diarrhea are probably unlikely to feel really well anyhow, and may need to not go into that shared therapy area until their diarrhea resolves. Anybody who is incontinent of stool or bowel movements, that's another group where you have to be very careful in having them come into a therapy area where there's a lot of shared equipment and a high risk of exposure to other people. It isn't an easy thing to manage in the long-term care setting, in rehab and skilled nursing settings. So using good judgment and being able to justify and explain your decisions is a really important piece to how you use precautions during the care of people with C. diff.
Okay, wonderful. Well, I think that's all the time that we have for today. Dr. Stone, anything you want to add before we wrap it up?
No, just thank you again to all of you for taking the time to join me this afternoon for this webinar, and thank you to ANAC. I do think we'll try to log all of the questions that were asked and provide answers to them, and I'll work with the team here to make sure that we can get you that information.
Okay, wonderful. Thank you. At this time, I did bring a survey up on your screen. If you do have a moment to fill it out, we certainly would appreciate any feedback that you can provide, as it will be used to help improve future webinar programming. So thank you for taking a moment to provide any feedback you do have. So that's all the time that we have for today. We want to give a big thank you to Dr. Stone for sharing your knowledge and expertise and being with us. So thank you, Dr. Stone. And we also want to thank our participants for joining us today and for your interesting questions and your interest in today's program. Again, this does conclude today's session. We hope you have a wonderful rest of the day. You may now go ahead and disconnect.